say empirically, now there are lots of terminologies, depends a lot how you practice and what your protocols are. But we look into the windows. You don't need very, fancy equipment. You don't need invasive monitoring and all to, make out that the patient is in shock. What we look at are five, six windows into the body that tell us that yes, the patient is not doing well. If the patient is dull, looks ill, is not as, in his usual state, the reason might be that he is going into shock. You come down a bit, if the tachycardia is there, hmm, then you might suspect that the patient will shock. The patient is tachypneic because he has now needs to, given more oxygen, needs to increase the supply to meet the demand, or due to respiratory washout, the CO2 goes down. There's metabolic acidosis or lactates are going up because of inadequate oxygen delivery, leading to anaerobic respiration in the cells. Your urine output goes down. So you just need a Foley catheter, or your blood pressure goes down and persistently is down. If you combine these, not one is usually taken into account because one of them can be because of other reasons. You might have a stroke and you are unconscious. That doesn't mean you are in shock. Okay, you might have anxiety, your heart rate, respiratory rate going up, but the other things will be normal. So at least out of these six, you need four criteria to be met before you empirically say yes, the patient is in some sort of a shock. So we use history, examination, lab criteria, and some radiology criteria to diagnose what type of shock we are dealing with, and thus obviously lead to the treatment. So if the patient gives history of chest pain, you have to think of certain things, most related to the heart or might have a pulmonary embolism. In a history of trauma, you would definitely will suspect hemorrhage leading to hemorrhagic shock, hypotonic shock, or if the areas around the chest, you can think of a tamponade effect or a pneumothorax. If the spine is affected, neurogenic shock will be one of your DDs. Uh, if the patient is septic, the so fever will be there, or any sort of immunocompromise or past history of infection will be there. Patient is on medications, you might have shock due to cardiogenic medication like calcium channel blockers and all. And chronic steroid use will give an idea that the patient is having critically crisis. Again, history of melena, hematemesis, any sort of blood loss, maybe hemorrhagic, vomiting, diarrhea, or if you have a stoma, high stoma output, GI losses will be up in the list of DDs. You have abdominal pain, perforation, hepatitis, inflammation, sepsis, backache or abdominal ache can lead to a diagnosis of triple A rupture if the history is similar. And inhalation to exposure to drugs and poisons can give you. So history gives a lot of idea. You points you to the right direction of shock and then later on to the management. So examination will pertain a lot to what we usually do the CNS examination, the general physical examination, cyanosis, pallor, uh, evidence of trauma, if they are descended vessels, which we used to read in Hutchinson. So examination won't vary, the general physical remains the same. The chest, you will look for edema, absent air sounds, okay, wheeze, evidence of pneumothorax, in CVS for murmurs and the muffled sounds. For abdomen, you have some tenderness or organ galley, CN examination, evidence of blood, all the survey, primary and secondary survey that we do in trauma. Then we come down to investigations, right from basic investigations like CBC, KFT, LFT will give you an idea of the organ involved, to cardiac biomarkers and ECGs, EVG analysis will give you an idea of which organ is involved, thus which sort of a shock you might be handling. In radiology, big thing that is coming up in ICUs and even in ERs is the point of care ultrasound. We'll touch a bit about it in the later slides, but we've been doing it on a very regular basis now. We do emergency and ultrasound from head to toe to rule out everything that might be seen even on CTs or CT scans or X-rays or echoes. You see pneumothorax, you can see fluid overload, you can see hypovolemia, pneumothorax, uh, you can see a positive fast scan in trauma. Okay, you can look for Dopplers and see for deep vein thrombosis. And echo will give you an idea of the cardiac function. The LV is down, LV is working fine. Pulmonary embolism sometimes might be seen, or RV dysfunction will give you an idea that is pulmonary embolism or a tamponade in the pericardial. Obviously, X-ray still remains there to give you a fair idea of what might be. So as I said, there's been advent recently of a lot of protocols like shock protocols and rush protocols, the rapid ultrasound shock protocol, which are done by experienced operators of the ICU. I'm not talking about radiologists, but ICU operators at the bedside, which give you an idea of what might have gone. So the rush protocol, for example, there are several ones, but I'll be touching a couple of them. You can go online and see all of them. So it gives an idea. It basically divides your cause of shock into three major regions. Whether it's the pump, that is the heart, whether it's the tank, that is the preload part, or whether it is the pipeline, that is the vessels which are involved. And then gives you an idea whether all four of them, which one is the more likely possibility. For example, if you are thinking about the pump, okay, in hypovolemic shock, your heart will be working just fine. In fact, it will be overworking to compensate. The chambers will be empty and it will be hypertonic. Whereas it will be the opposite in cardiogenic shock because here the heart is hardly working. The heart is hardly working. So it will be hypocontractile and dilated. Okay. If it's obstructive, you will see that though it's hypercontractile, but the right side will be strained. You might see a thrombus, okay, or effusion at the pericardial region. Okay. And typically distributive shock is a high output state where you'll see that in the early phase, especially the heart is working overtime. Later on, if myocarditis is there, then it will settle down and go to a hypo. Same goes for the tank. You see flattened IVCs. You'll see fluid losses in other parts. Might have a EFA scan positive in cases of uh, bleeding is present. In cardiogenic, it will be the opposite. The IVC will be distended. The pulmonary edema will be there. Back pressure changes will be there. Similar in the IVC, except this won't be in the lung, but the IVC and the jugular region. But if there's a pneumothorax, you see an absent lung slide. And in distributive shock, you might see, be able to see the source of sepsis or normal or dilated collapsed IVC. Pipes is still DVTs or aneurysms or ruptured aorta are some of the morphologies that you might see in the rush.